Morning. This is the heart failure section of the Cardiology Fellows Bootcamp. Our first talk is 30 minutes. I would like to introduce our first speaker, Dr. Arvind Bhimaraj. He's our medical director of the Advanced Heart Failure Therapy VAD Transplant Program. And he's going to be talking about acute decompensated heart failure and cardiogenic shock. So over to him.
Thanks, Imad. I think now that all the boring stuff is done in the morning, we can get more interesting aspects of cardiology, right? Are there interventionists in the room? No, good. All right, guys. So the aspect about acute decompensated heart failure, and the reason why I put this slide up is you want to recognize very clearly that it's a different syndrome. A lot of heart failure, what you learn about beta blockers, AC inhibitors, everything that you see, technically has nothing to do with acute heart failure. And in one essence, the reason we've not made much progress in acute heart failure in outcomes relies on the fact that this demarcation is sometimes missed. So it's the acute changes, the hemodynamics, the neurohormonal changes in the acute setting with certain unknown aspects of immune mechanisms are still quite an enigma that there's not much that you can do to modulate an outcome from therapy in these individuals. So keep that in mind. And so if you look at the various kinds of acute heart failure is a very broad term. Heart failure is a broad term. And you need to remember that when you tell patients and know exactly which cohort you're talking about. But when you look at the slide with the percentages onto the side here, essentially you could be dealing with pulmonary edema, you could be dealing with just an acute decompensated over chronic heart failure, ACS and heart failure, right heart failure, cardiogenic shock, hypertensive acute heart failure. And there's a differentiation over there. If I make any of your blood pressure 250 over 110, theoretically you will be in heart failure because you'll be in pulmonary edema. And there's a classic distinction of that from someone who has a myocardial energetics problem and not able to pump. So hemodynamics, myocardial problem, right heart, left heart, all these need to be looked into when you're talking about acute heart failure in an individual. What happens in acute heart failure? And a lot of the discussions in acute heart failure will probably center around LV failure, even though RV failure is important and need to be distinguished. So this cartoon that you see represents your wedge pressure, right? The wedge pressure or the pulmonary artery wedge pressure is where you put a PA catheter into the pulmonary artery, inflate a balloon so that the tip of it sees the distal pressures, that's your left atrial pressures. So if the left atrial pressure is about 12 that you see over here, and the lungs, the pulmonary artery, the lungs, and the left ventricle. In a normal state, these pressures are, of course, reflective of the left ventricle, and being normal, you don't feel short of breath. When you go into hemodynamic congestion, what that means is your filling pressures will increase. Left atrial pressure will increase, the wedge will increase, but you don't feel short of breath. You don't see these curly B lines, and I'm sure by the end of your fellowship, if you pay enough attention, you will see patients walking around feeling great, but their filling pressures are high, and that is hemodynamic congestion, which will then lead to pulmonary congestion, is where you see X-ray changes, because this fluid is essentially seeping into the lungs. And you'll find X-ray changes. The patient still might not be symptomatic. You might find some pleural effusions, and then that leads finally into clinical congestion. Now, the lag time for an acute decompensation can range anywhere from 15 to 30 days. It depends on the acuity, it depends on the chronicity of heart failure. But it's important to remember these classifications because you can have high filling pressures, not be symptomatic. The reason you feel symptomatic is much more complex than just pressures, right? What are the receptors in the lungs that make somebody feel it in the brain? Anybody? J receptors. So there's a whole neuronal pathway for you to perceive it. So remember that there are variations. If someone's in acute decompensated heart failure and is 25-year-old, who's sitting and talking to you, that doesn't mean they're not volume overloaded. What happens in acute decompensated heart failure? It's not just the heart, but your entire body is getting affected. You have neuroendocrine markers that go up, flogging the heart, but all these things cause changes in the lung, the liver, because of low output and because of volume overload and congestion. So you have to be mindful of looking at everything. If somebody's liver function is off and they don't look volume overloaded, you have to suspect that they could be volume overloaded. And the physical exam, I'm not going to go into the details of it, but is not always 100% reliable. In an acute decompensation, it's not as simple as volume overload, get a shot of Lasix, and go home. And a lot of patients end up believing that. I've had patients who say, oh, at Christmas time, I come and get my annual Lasix IV and go because I eat bad. It's not as benign as it is, and you need to understand that and you need to enforce on that. Every time you get an acute decompensation, like you see in this graph, you fall off of the survival curve, and you never regain back the survival that you were on as a chronic heart failure. And because of reasons that I explained, that we're not doing anything to modulate that pathophysiology when somebody comes into the hospital. All we do is Lasix. Does Lasix have any mortality benefit? Nope, no benefit. In fact, there's controversy that it could be detrimental because of neurohormonal modulation. And a little peek into what happens other than neurohormonal modulation, and this is an active area of research and pathophysiology, and our center and our lab has done some of this work. But if you think about it, no matter whether you have coronary artery disease, ischemia, or not, even if you take 100 individuals who are non-ischemic cardiomyopathy, patients who have higher troponin do worse than patients who don't have high troponin. It has nothing to do with an MI. And if you think about it, it's myocardial damage. But if there's a short period of myocardial damage and you put them on medications, why don't they do better? And an area of pathophysiology that's being elucidated is the fact that your immune system, once your antigens of your heart get exposed, your immune system gets activated. We're not doing anything to counter the immune system. And this work, which was done by one of my partners, actually documents that in acute heart failure, if you notice, the B cell activation peaks in about 48 hours. And then as it comes down, as the heart failure gets better, the B cell activation gets better. And we've published a paper showing that B cells, if you take B cells off in a mice model of heart failure, actually the heart failure phenotype becomes completely down. In the world of heart failure, a lot of T cell therapies have been worked out and didn't pan out. So I think there is more to immunology in an acute exacerbation than what we know of. And the fact that we don't have anything to treat needs to be remembered. And in fact, the focus is avoid an acute exacerbation. See patients in the clinic and make sure they don't get into acute exacerbation when they get there. If you go through the guidelines of what do you do when somebody is hospitalized for heart failure, the only thing I'll point out is all the level of evidence is B. And you guys know what these level of evidences are, right? A is the most standard with large clinical trials. There's not much that panned out. And I'm going to just skip through saying that there's not much evidence to do what you do in an acute exacerbation as far as trials are concerned. This is one of the classic slides that you want to walk away from when you think about acute heart failure. This slide signifies that every admission a patient has in their lifetime portends a bad prognosis. The first admission, first hospitalization in their lifetime, 1-year mortality is about 34%. You have a fourth admission, which is this yellow line. Right up here, you can see at 1 year, your mortality is getting close to 50-60%. And how many times have you not seen people come in and out of the hospital multiple times? So this slide really reflects the fact that you want to be mindful of the fact if patients keep coming back with an acute heart failure exacerbation, that they're not going to do well in the long term. Moving on to a more serious spectrum of the acute heart failure that we talked about, which is a cardiogenic shock. These are patients that you will see, right? 50-year-old, low EF for many years, come in with shortness of breath, lethargy, tiredness, and they're cold and clammy on touch. Sometimes they're not cold and clammy. So remember that your formulation of diagnosis and a plan is not based on one data point. And a lot of people might be warm but still be in cardiogenic shock. And in fact, I not published my personal, that I've realized is your kneecaps and your toes are probably much colder than the rest of your legs because they're much anterior. And I've had patients who, if you touch the leg, it's going to be warm, but your kneecaps are much colder. So keep in mind that you have to put everything together. So this patient, even if he's warm and perfused, if you feel like that, you have to keep in mind that your lactate is high, total bili is high, BNP is high with a low EF, and INR is high. So this is essentially cardiogenic shock until you prove otherwise. So what is shock? A shock is inadequate organ perfusion to meet the tissue's oxygen demand. And it's the organ perfusion that you have to keep in mind. And if it's cardiogenic shock, the reason is the heart, right? If someone is in shock and it's the heart, that's when you call it cardiogenic shock. The classic definition has focused on blood pressure being less than 90, MAP less than 60, or systolic blood pressure more than 40 points, less than baseline. Now, you have to take this with a grain of salt, because if someone's blood pressure is at baseline is 200 over 100, that doesn't mean someone's in shock if it's 40 points lower. But in the right clinical setting, blood pressure is important, but blood pressure gets more value than it should. What that means is you can be in shock and be hypoperfused without significant hypotension. And you need to recognize that shock. So cardiac reason for cardiogenic shock is essentially meaning that your cardiac output is low. If your cardiac output is not low, you can't call it low perfusion because of the heart. You can be in congestion but not be in cardiogenic shock. So, and the cardiac output is dependent on your systemic vascular resistance, your blood pressure, your heart rate, and these all equations are important when you go by the bedside, and I'm sure the fellows who round with me know simple things like adjusting the pacemaker rate to a higher rate if someone's in cardiogenic shock because they don't have their native rhythm, as what is reflected in this graph, that you have to keep in mind that cardiac output is relevant in all these hemodynamic parameters. Of course, shock, that's the good part. As you're evolving in your career, you realize that patients don't come in chapters or textbooks, and they don't come with labels of diagnosis or multiple choice questions. They always have multiple things going on. So it's very important to make sure they don't have other diagnosis, and not just other diagnosis, but it's a combination of diagnosis. You can be in septic shock along with cardiogenic shock. Which is playing more role at that time is what is relevant. So keep that in mind, that you rule out things that you can reverse: hypovolemia, obstruction, distributive shock, dissociative shock, which I'm not going to go into today, but you are an internist first, then a cardiologist, then a subspecialist. So don't forget your basics of making sure you rule out everything. Otherwise, you're going to misdiagnose. And we've seen patients transferred to us as cardiogenic shock because their legs are cold. Essentially, there were 2 occlusions in both the arteries, and there was dead legs. The EF was low, right? So I think make sure you remind yourself that you got to go back to your basics. Shock is bad. That's all you got to walk out from here. It's bad. Know about it. Make sure you think about it. Make sure you rule it out, and make sure you act on it appropriately. The mortality, as you increase your inotropes and pressors, just skyrockets. That's another simple equation. Somebody has a cardiac problem, mostly a low EF, and they're going up on pressors. Don't just sit on it because the blood pressure is high. You use two of dobutamine and they're doing okay and they're great and sitting and talking to you, that's fine. But you're talking about non-epi, epi, going up on the pressors, you're already lost the chance. So don't be an overnight fellow who did not call your attending until you're on 20 of Norepi. Right? Wake up people in the middle of the night because this is very time sensitive. How do you manage it? You get 2 seconds to memorize this, and then I'll ask you questions. So if you, and a part of management is knowing what you're treating, and a part of management is knowing what you're aiming for, and knowing the tools that you have available. And we can't cover everything today, but we're going to expose you guys to things which you might not have seen during your rest of the training in the context of mechanical support and other aspects of cardiology. But when someone's in shock, if someone's hypotensive, you could use any of these medications, the only caveats being both dobutamine and milrinone will lower your systemic vascular resistance apart from being inotropic agent. If someone's very hypotensive, systolics in the 70s or 60s, these medicines are not going to be enough. And I would probably not even use them. You would go with dopamine, you would go with norepi or epi. Now, there are a couple of trials which looked at norepi and dopa, and there's a favor for norepi for what it's worth. But end of the day, what's important to remember is milrinone has a long half-life, and if you start milrinone, it's not going to work for about 6 hours. We have gotten away from doing boluses for milrinone because boluses are more harmful and you could drop the blood pressure. So if someone's sick, you got to do the dopa, norepi, epi, whichever, to maintain the blood pressure, and then figure out if what inotropes you need. But essentially, as I said, if someone's hypertensive, your systemic vascular resistance is high, because of which the cardiac output is low, you put them on a low dose of dobutamine and they get better, that's fine. But if you're going down that slippery slope, you have to think about mechanical support for the individual before it's too late. And you're at moderate doses, you have 7.5% mortality, 1 high dose, 21%, 2 high doses, 42%, 3 high doses, 80%. And keep this in mind, I'm sure you will find people who are on 8 of epi, 20 of norepi, 5 of dobutamine, which is almost common when patients get moved over to higher level of care centers. So make sure you catch these things early on. So what are the mechanical device supports that you can use? Right? Intra-aortic balloon pump is the most prevalent, most easily available. I'm sure some of you guys who have been savvy and exposed to the world of interventional, I heard there are a lot of interventional blasts here. And a lot of them are emerging interventionalists. You're already thinking, oh, balloon pump is useless, Impella is the best. If someone's thinking about that, we'll talk about it in a minute. You have Impellas, which is range from 2.5 flows to 4 liters, which is a CP to 5.0 Impellas, Tandem Heart, and then ECMO. We'll talk about each of one in a bit. Before you go down the path of mechanical support and which one to use, I would urge you to read this scientific statement which was published in 2017, just last year, talking about shock with a more focus on STEMI. And what has been very well organized in this paper is the fact that as you're resuscitating, and if it's ACS, you reperfuse, or PCI or CAB, whatever you do, you have to keep in mind that they might recover. If it's a STEMI situation, there's a hope of recovery. But they might also not recover. If it's an acute and chronic heart failure, 2 times CABG, nothing to revascularize, they're not going to recover. What do you do when they don't recover? You have to keep that in mind depending on the center you're at. Do you talk about trying to bridge them to a durable VAD? Do they take them to transplant? Or give up and put them on palliative care? This whole paradigm needs to be in mind so that wherever you go and wherever you become a cardiologist or interventional cardiologist, you need to know who your backup durable VAD center is, who your transplant center is, so that at the right time you can ship people over. And it's the systematization of shock which is more important than using which machine versus other. So I would urge you guys to read this. It's a good document. And certain concepts of shock are, it's not just assessing the adequacy of the interventions that are important, assessing the recovery of the organs that are important, and monitoring the recovery of the heart is extremely important if you're in the setting of STEMI or any other recovered myocarditis, but everything is time sensitive. Also, majority of your training you've spent in learning about lactate, renal failure, liver failure, and think about it, why are we not talking about a heart and cardiogenic shock? All we're talking about the body. So as much as the body is important, you need to remember that you have to optimize the cardiac hemodynamics. You need to think that the heart is under stress. You put them on 20 of Norepinephrine, the body is okay, your blood pressure is okay, but the heart's dying. So performance measures of the heart are blood pressure, cardiac output, CVP, LV, EDP, but the cardiac load is extremely important, afterload, preload resistances. And just last week, there was all the interventional blasts. Last week, there was a publication in JACC about recovery after unloading and reperfusion. So the concept of revascularization is also changing, that you actually have to rest the heart, unload the heart, so that it recovers better and not just kind of do things and walk away. I'm going to skip that part for now. The other thing is, do not hesitate to use a Swanganz catheter, and don't become the interventionalist of the past where you're against a Swanganz catheter or an ICU person of the past because you're against a Swanganz catheter. There's role for both, but don't hate swans, okay? Look at the right evidence, and there are indications right now in the guidelines, and class 1 indication is if someone's in cardiogenic shock and after a STEMI and you can't figure out what is contributing to it, float a swan, but you got to know how to use it. And I know we have arguments in our center with my interventional colleagues. They're appropriately skeptical because if you put in a swan and people react wrongly, of course you're going to harm the patient. So you have to learn hemodynamics, and today's shock world is filled with hemodynamics. And this is the first snippet of evidence from the Detroit Shock Initiative showing that if you have hemodynamic monitoring, you actually improve outcomes. And this is the first snippet, but of course you have to train. So the Detroit Shock Initiative has trained people in making sure that you use it appropriately. So let's quickly go over the physiology mechanisms of all these pumps. So intra-aortic balloon pump essentially works simply, if you have to remember, take your fists and then move both together. If one is a heart and the other is a balloon pump, it's being timed at the same way, which means that when the heart, if this is the heart, if the heart is in systole, the balloon is deflating, which means that in systole, the deflation unloads the heart. In diastole, the balloon inflates, which means it pushes blood back so that you perfuse the coronaries. If you don't imagine this way, I've struggled for a long time, systole, diastole, timing, inflation, but those are the two functions of the intra-aortic balloon pump. And the anatomy of the balloon pump, it goes through the groin, you can put it through the axilla also, but essentially rests at in the descending aorta, right by the bifurcation of the trachea, and then the distal part should sit above the renals. On the X-ray, you try to make sure that the position of the balloon pump tip is somewhere by the bifurcation of the trachea. Now, Tandem Heart is the next pump. The Tandem Heart is a pump that goes in transeptal. So you have a venous cannula that goes up all the way, goes into the right atrium, and you do a transeptal puncture and leave the cannula in the left atrium, so you're sucking oxygenated blood. It comes all the way out, and then you're pumping in oxygenated blood into the iliac artery, and this you can use as a cardiac support as long as you don't have oxygenation problem. Again, the Tandem Heart console looks somewhat like this. You can flow up to 4.3 liters, and you essentially can maintain good amount of perfusion with the Tandem Heart. The Impella device is an axial flow rotor pump, and you see the different sizes, but the concept is it's an arterial puncher. You go all the way up, and it crosses and traverses the aortic valve and sits in the outflow in such a way that blood is sucked in from here and then pumped out here. So your aortic valve sits somewhere here. So essentially, you're sucking blood from the LV and then pushing it out into the into the aorta. Now, if the hemodynamic benefit of unloading is reflected in this pressure volume loop, and I don't have time to go into the basics of what we are looking at, but essentially, this is a acute heart failure state, and you see that the LV EDP is high, and the energetics of this particular loop is reflected here of about 22, and as you unload it, your energetics come down to 20. And pressure volume loops are a very good reflection of the energetics of the heart, which you sometimes forget. So there's definitely a role of unloading the heart and decreasing the LV EDP. You can use the Impella, where we use a lot of the 5-0 axillary Impella, where you can get up and ambulate and move around. So that's an advantage over the Tandem, which goes through the groin. And again, various speeds that you can use. One other concept you want to touch about in shock and other devices is the fact that your aortic valve opening is important to keep in mind. This is a patient with Tandem Heart, where it's a continuous flow pump, so it's a flat line with about 84 MAP, which is okay, except that you have to remind yourself that the valve is not opening. And if you use milrinone, you can start actually seeing the ejection, and I'll show you a reflection of why that's important in a minute. ECMO is the last pump to talk about. A peripheral ECMO, the concept is you suck blood from the right atrium and then get an oxygenator because you're avoiding blood from going into the lungs, and then pump in oxygenated blood into the aortic system. So essentially, an extracorporeal membrane oxygenation can be used in a cardiogenic shock setting, very conveniently put it in at a bedside. Now, the concept of aortic valve opening is what I want to show you quickly. This is an example of a heart. This is a transesophageal echo, and this is your LV, RV, left atrium, and right atrium. When you have an ECMO or any aspect of a device which is pumping blood into your aorta, your heart has to struggle against that. And what you see over here is a patient on ECMO in whom the heart's so weak that it's not able to pump blood out. And then over here, essentially you give milrinone and then optimize the aortic valve opening, all that blood becomes better and stagnation goes away, except it's too late now because it went to the brain. So remember, the concept of aortic valve opening is important in patients who get mechanical support, which increases afterload for the heart. And if you don't think about the heart and just think about the body, you'll forget about it. Now, we won't have time in going into monitoring hemodynamics, but I want to make sure that you understand you need to know how to level, know how to get the measurements in any patient with hemodynamic monitoring, and that'll be key for you. And the guy who's sitting down there is not an intern or a fellow, he's the chief of our all ICUs, that's Masood, who's down there getting all the measurements. So keep that in mind, and make sure you understand the concepts of Swanganz. And garbage in is garbage out. If you get wrong measurements in your head, you might be the smartest person, you're going to make wrong decisions. And that's why it's important to know all these hemodynamics. I think with that, I'm going to actually stop here because we're running out of time. And essentially, you have to remember time is of essence, know your options, and any device is better than no device. So whatever you have available, using it is probably more appropriate than not using anything and trying to talk about evidence which might not always be relevant. Thank you.